Great. Well, thank you very much, and it's a pleasure to be here with you today. I'm usually spending my time speaking with health and health policymakers, and it's rare that I get to spend time with as many technologists, so I'm looking forward to the opportunity to be in San Francisco as well. And I expected that public sector and government wouldn't come up so much before I was able to speak today. But I think it's exciting that Sanjeeva talks about the WSO2 culture as being open and transparent. And he said, essentially, all the emails internally are public. So that makes a lot of sense for a public sector entity where most of the work we do is public. And I think Tim talked a little bit about the opportunities for work that may not be as trivial as some of the work that's gone on in technology. And as I've transitioned and done some work in health and the public sector, I've learned a lot about the work that's done and the challenges that are faced by public sector employees. And a group that I've done some work with is called Change and Innovation. And they're a group of people who have worked in the public sector, but they like to say that the work of government is noble, the people are good people, but many of the tools and technologies that are available in the public sector, the systems and the processes, are real challenges to getting work done. So today I want to talk a little bit about the work we've been doing in South Carolina to really modernize the environment to make that work possible, to improve the experience. So I want to start by asking the question of who cares? Well, I'm going to suggest that at the beginning, families like these care. Families like these are challenged by a user experience that in South Carolina, through October of last year, was primarily paper-based applications for the Medicaid program and for other government programs. They're families that we're trying to give government benefits to, and we want them to be employed, children in school whenever possible. But we make them fill out paperwork. We make them show up to offices throughout the state between 8 and 5. How many of you would interact with a business that required you to fill out paperwork and show up and drop it off between 8 and 5? One guy wants to take me up on that. I'm going to argue it's not a great experience. We haven't modernized government in the ways that many other industries have been modernized. And we're going to talk a little about a government, Medicaid, and healthcare as well, which adds all the challenges I think we heard about in the ER, moving data on CDs. But I'm also going to argue that all of us should care about this, especially those in the United States as taxpayers, those around the world who are impacted by the economy in the United States. So we're going to start by asking a question. We're going to take a little poll and talk about healthcare spending in the U.S. So for those of you that have seen this before with Poll EV, if you text to 22333 and use any of the numbers in the body across the bottom, or you can go to the website as well. So this is interactive. You have to pick up your mobile device here. Yes, you have. One time the speaker is asking you to not pay attention and grab your device or your computer. And we should see in a few seconds here as data comes in, what do we think? Healthcare spending under $100 billion? By about 500 million? Up to over $2.5 trillion on the other side. So there we go. This is something I talk about when I talk about to people in health and health policy. What are we actually spending to deliver health services? So we'll see. We'll let that go. We need music here, I think, in one sense. So we'll see here. Okay. That's a good start. So we have a few people down at the bottom end. Most people, number of people up at the top end, and some people between $1 trillion and $2 trillion. So the health spending in the U.S. has been up around $2.7, $2.8 trillion for health services. I don't know, is that good or bad? Well, I'd suggest it's good or bad if we know what we're getting for it. Now, this is an industry where the spending has continued to go up. And if you read the current media, it's excited because last year, in 2013, we've got some data that suggests for the first time in a while, it's grown a little bit less than GDP. But think about those years that were tough economically. Continued to grow by about 4% a year, when real GDP growth was a negative 3%. And as I said, well, I don't know, is $2.8 trillion a good number to spend or not? It seems to me that the question to ask is, what are we getting for that? Well, I'm going to suggest that we aren't getting the value we should be. This is some information about life expectancy for white women over the last 3 decades as it's correlated or related to education. And actually, for those women with less than a high school education, life expectancy in this country has decreased, according to this data. Likewise, as you'll see, the United States, health-wise, the health of its population is falling relative to the world for that $2.8 trillion investment. And as I just suggested, there may be a correlation between health and education that may even be stronger than what we're spending on health services. But at the same time, based on data from state governments, spending on Medicaid, the program for the poor, those in need at the state and federal level, has eclipsed spending on K-12 education. And the Institute of Medicine in 2009 spent some time studying this, and it suggested that about 1/3 of what we spend, $765 billion then, I think the total spend was about $2.4, $2.5 trillion that year. More than we spend on defense in excess. Enough to fund other programs, and more than we spend on other infrastructure projects. And you'll see some of the reasons or some of the areas where they found excess cost. Again, a lot of it isn't just fraud. Unnecessary, duplicative services, administrative waste. And you may be familiar with articles or books like this in the last couple of years in response to some of the challenges in the health system. We can do better. Former CMS Administrator Don Berwick really brought about this concept or pushing towards something that's been referred to as the triple aim. How do we reduce the per capita cost of health care, which you may be familiar is about twice in the US as most other industrialized nations, for not as good outcomes? How do we shift our thinking away from just delivering health services, but driving towards thinking about population health, the health of individuals, the communities they live in, our overall population? And how do we improve that patient experience? How many of you think that it's the best experience? It's Uber-like when you schedule an appointment and go and visit the doctor. No takers on that one, huh? So I asked the question, what should we do about it? How do we figure out how to focus on health outcomes, not just those services people access? How do we think about health value? The notion of, are we healthy? And how is that related to the amount of money we spend? And how do we use innovation? And that's what I want to spend the rest of the time talking about. How we can use innovation, and particularly technology, to do better in health services. So we need to shift our thinking. And I'm going to talk for a minute about the Medicaid program and what we do when people apply and enroll in the program in South Carolina. And it's pretty similar across the country. Some states have done some better jobs. Other states are still lagging behind the work we've been doing in South Carolina. And as I said, until October of last year, the process required paper. And what I mean here is that 100% of the work that our employees do in eligibility and enrollment for the Medicaid program involves collecting paper, analyzing the paper, requiring more paper, checking the paper, putting it into a computer that really just keeps track of who's in the program, and then telling people that they're eligible. What about this actually makes people healthier? The shift that we're trying to work towards in where technology, open solutions, framework thinking, platform thinking has to drive us is when I talk to the team that's working on transforming this process, that eligibility and enrollment may be only 10% of what we do and what we care about. It's all this stuff over here that's possible when we have a platform, when we connect and share our information, and we make use of it around people's experiences. It connects to healthy living. It connects to apps. It connects to software. It connects to scheduling experiences. Right now, we take in this application, and although you can now do it online, you still have to wait to determine if you're eligible for the program. Shouldn't the experience look something like, give me some data, allow me to check that data electronically, choose a plan because Medicaid has different plans like your own health care, figure out who the providers in your area are because we know where you live, maybe schedule that initial appointment because we know that primary care matters for healthy outcomes. And couldn't that whole experience be something that everyone in this room believes we could develop today and should deliver? And then we connect to healthy living. And this is why thinking from a platform perspective is so critical to our state's Medicaid program, and I would argue many states, and actually drives different behaviors in Medicaid and government. So, from a security perspective, Bruce had talked about the notion of a single tool versus buying a bunch of best-of-breed tools. And I use this because I'm going to talk about something called the MMIS. Has anyone ever heard of this? One person clearly has worked either in government, in the vendor space, or otherwise related to Medicaid. Well, all it means is the Medicaid Management Information System. But this is a system that I think looks a little bit more like the board cube than any technology that I would be interested in building. And why is it? It's very closed. It's a closed system. Those states whose MMIS have some APIs, they were built on the edge, usually with some odd integration. Most of the data exchanges in and out are flat files, and I'm going to show you a little bit about that. They're very expensive to maintain, and more importantly, they don't allow us to innovate. So I've been talking about and working on how we change the future of MMIS for Medicaid programs. And I'm going to suggest we need to take this and destroy it. We need to think about a modular MMIS. We need to think about breaking this up into components that make sense, that are based on enterprise services and open source platforms that allow us to think about reporting and analytics separately in nearly real time. Our finance and administration, the payment associated with Medicaid, who our providers are in our state. The Medicaid program usually works with a large number of them, but our providers have to do duplicative services, certify separately, for different programs. In our state, our teams come up with something that they want to call the operational data store, or are calling that. Because right now, most of the data we have to run our program, at best it comes back to us a week later. It typically comes back a month later, and a good part of it comes back a quarter later. You can't adjust a program dynamically if that's the speed of data. And I don't see all of the users' experiences. I don't know that they've called our call center 10 times, and over here, they're asking a question about policy. We don't have that insight. Government must have the same insight that running a CRM system at any company has. And we're trying to outsource those things that are like other outsourced services already available. And here I talk about the Administrative Services Organization. Well, what that means in healthcare and the insurance industry is somebody that pays the claims, handles some of the financing. Well, states across the country have argued that Medicaid is so different that commercial insurers who do this all the time can't possibly be in that industry. And we're challenging that assumption in South Carolina, because what we're doing is instead of saying, you must do it the way Medicaid wants it done, we're saying, how is commercial insurance and how do competitively many organizations bid and deliver services for commercial insurance? And what's different about Medicaid? Well, no longer are we going to put that burden on others. How do we take that burden to translate the Medicaid differences so I can go and buy services as a commodity? And at the same time, we have to build in government basic enterprise services that many of you in your industries or your businesses take for granted. How to get collaboration and communication. How to have shared document imaging systems. We don't have those because we've typically funded, operated, and managed our systems and programs from a perspective where everything's siloed. So this is a schematic that our team developed of our current system. And the most interesting thing I'm going to point out here are everywhere you see one of these little triangles that I think are mostly, or squares that are mostly orange, those are proprietary flat file interchanges or exchanges that somebody came up with a long time ago, but over time have become the inner workings of our system. This is why it's so hard to innovate. Not even sure which of those lines to cut and put in a good service. So our team is working on rethinking what our enterprise looks like. Thinking about it from services first, and then being able to interact or interoperate those services with other entities. And in doing this, we're trying to think very differently. And I want to talk about a project that our team had put together earlier this year. One of the challenges in the healthcare industry is a lack of transparency. Some of the previous information where I talked about the Time article, the other book about how healthcare killed my father, price transparency in healthcare is really not existent. I challenge any of you to walk into a doctor's office and ask for the services and the prices. Do you think you'll get it? Do you think it'll represent what you may pay for those services? Well, in South Carolina, we think that's one of the many factors that contributes to the challenges in delivering health services. So we've been working on a health transparency site. Unlike many of our other projects, where it may take months to make a minor change, we developed this with open source technologies in a matter of months, taking publicly available data we have already within our network, and building it into something that had a strong user experience. Our team's been working on this for the rest of this year to continue to add. Initially, we had hospital data. We're adding nursing home data this month. I think we added data about our FQHCs, or federally qualified health centers. And we're working on procedure data as well. And you see this trend going on in many areas. to change healthcare and to change the health delivery, we think more information needs to be made available. So in Peter Thiel's new book, 0 to 1, and we heard about this from Tim earlier, I think from Sanjeeva, from the work at GE, we have an eligibility in our state about 500 employees. I think they vary in their thinking that my job is to take their job away. It needs to be a transformation of thinking that it isn't the job that needs to go away. It's how do we provide value-add services. Moving paper from one place to another is not a value-add service. It doesn't improve our citizens or our customers' experience. There's a tremendous amount that is imaginable, that is possible, and I'll go back to the right side of that picture I showed about what we can do in healthcare, in government, and in the public sector to change the experience for our citizens, to change how we use the dollars that our taxpayers provide. And it's that imagination that we need to base government on as we move forward. And I think Tim talked about some of the work at Code for America, which is one of the organizations. There's work going on at a group called OpenGov.com to bring data and analysis and make it available. Brian Civic, the CTO for the Federal Department of Health and Human Services, has been building a project called the Idea Lab to give HHS employees the opportunity to experiment. It's that shift in culture, transforming what we think about and expect from our government, along with technology innovation that I believe is founded in open source technologies, platform thinking, that will actually move us to make, in my opinion, a next generation MMIS possible or imaginable. But we have to think about moving things very differently. So thank you. Absolutely.
Do we have any questions for John?
So that was all crystal clear. Oh, no, we have one.
Let me get to this person. Where?
Hi, thank you for the presentation. What WSO2 stack do you use for this transformation?
Right. Certainly. So we do not have any WSO2 work in production today. We are working with the WSO2 team to look at the app server and the ESB layer that we already have some work in place. We're also, as we move into a more DevOps thinking, working with the app factory in the app API manager as we think about how to make our environment more interoperable and accessible. As open source technology and on government procurement, it makes it easy for us to bring in the technology to really experiment with it. And we've been working with the WSO2 team for probably, I think, about 8 or 9 months on that experimentation. And if those are, they have the benefits that I think we're seeing, we'll start to move them into production over the next probably year or two. Oh, is that a question? No? Oh.
Thank you very much for the presentation. So I was wondering if you could elaborate on APIs and how you're looking forward to leveraging API management if you're looking to extend your APIs to like the provider community and facilities and things like that. Absolutely.
For those that have worked in the healthcare space, it's challenging. There are not a lot of standards. There are standards around some health data. There are primarily EDI-based standards around claims and claims processing. There are limited information about who's in a program or out of a program. So we're starting with modernizing our EDI layers and building on those. For things like providers and provider networks, there aren't really standards for how you talk about a provider, who's in a network, who's out of a network. So we're working internally and with industry groups to try to define good XML standards for how do you keep track of those people, the updates, manage what you might call master data for those. Also, the transition from EDI to XML is happening in the claims area, so we're trying to be ahead of that. And then particularly as we look at APIs and interfaces that are available through other companies, businesses that are working on healthy living applications, interactions with either medical devices or general exercise, we're trying to make room for those in our overall planning and enterprise so that we can collect that data, so we could imagine a future where we're able to deliver more value about the health outcomes to those people in our programs. Certainly.
Oh, yep.
Just piggybacking on the previous question, if you were evaluating a population healthcare platform, what kind of APIs would you look for?
Would we require? I'm not sure that the notion of require would be ready to answer that, but there's a whole set of standard ones on the EDI transactions, which for those that work in the space, the 200 and 800 series transactions, moving those to XML. Most of the population health programs or systems that I've seen depend a lot on HL7, which is an international standard that gets more away from the claims and the coding, but looks more at the health record. For those working in this industry, you may be familiar with a lot of the EMR incentives that have been offered that really came out of the Recovery Act. We're still slow to adopt those, and I think the challenge becomes figuring out what data is salient or pertinent in the data that's available. And I think the question isn't so much about APIs and data exchanges. It should be shifted towards what information about a population health platform, system, or analytics tools actually allows us to deliver or find that information that is actionable, should be acted on, and is important or pertinent to the population that we can actually change. And I think that's where there's both exciting work going on, but that's where the opportunity is. And it's going to involve an awful lot of making sense of not just those sort of traditional health interfaces, but social data. How do you start to bring in social information about either where people are, what they're doing to either offer potentially health tips, population or community health information about what may be going well or not so well. One of the challenges of building health policy that we've been working on at a state level and at a federal level is so much about the health of a community is about the community. So how do you shift that thinking as well? So I think there's some standard transactions that one just needs to have. There's some novel information that is probably unstructured data that is creative and differentiating. But what's really important is to figure out what can we act on, either directly or through policy, to actually change behaviors in a community to drive to health, to either a better health of the community or population health.
I think we're often discouraged about seeing innovation come up against political gridlock and special interests and patronage and lots of other things. Is there something about open source that you see can really help overcome that or navigate between those shoals?
Absolutely. I think the biggest thing, and one of those challenges, to turn what you said into possibly one word, is government procurement. I mean, government procurement, when I hear from the people working in the MMIS space, is one of the big challenges. I think open source has a huge opportunity because, like our health transparency site, like some of the work we're doing to build APIs, open source gives myself as a CIO the opportunity to bring things into our environment, to test them, to set up an API to show that value without some of the procurement challenges. So I think that's one place that's really important. I think the other place that open source itself may not be a helper, but is an inhibitor, is it allows that interoperability with a lot of other players that may not have been able to participate in a government procurement. So one of the things that we hear, particularly from smaller or innovative companies, is, well, you've got all these procurement rules, you've got all of this contractual language, but we're just a small company trying to innovate. So that open source may be an opportunity to allow and give space for that is likewise.
So thank you for sharing the stats, especially on women and the correlation with education. But out of the $3 billion
Trillion.
trillion
Nearly $3 trillion.
How much of it is inefficiency and that could be cut, like the work that you're doing, and how much of it is also better living habits, that maybe other societies have and not in the U.S.?
Right. So again, on one piece, I showed you what the Institute of Medicine said about how we deliver our current health services. But I'm going to talk for a second about something that within the health policy world is generally referred to as the social determinants of health. So this model essentially says that the health services, what we're spending the $2.83 trillion on, actually benefits health probably somewhere between 10 and 20% if you're looking at the overall health. So that leaves a lot of space where education, healthy living, environment, transportation, housing, all of these other things contribute to health. So I show that information about education. It involves all of these things. How do you make a community healthy? You need to deliver more than just health services. So with that, in our state, myself personally, as well as I think a growing number of people across the country, are talking about not just here's health services and what we spend, but especially in helping those that are most in need. How do we drive helping them with all of these other determinants or social determinants that drive better health? And I think some of these platforms, interoperable information, will actually help us improve across the board.
Hi. Thanks. That was a great presentation. I was fascinated when you talked about HL7. I remember working on HL7 almost 20 years ago, the clinical data, and you were saying just making it into outside the clinical data. So why do you think it took so long for a standard like that to come into outside of the clinical data, one? And the second part of the question is, how are you planning to bring in the patient-generated data? There's more and more patient-generated health data, and where do you see that fitting in? Is there a place for open source in this whole patient-generated data?
Absolutely. So the first one I'm going to say, I can't figure it out as a technologist. A standard that's been around, it's not 7 because it was version 1, right? It's HL7 because it's version 7. We have been very, on one hand, private about our healthcare data. We've had a very separated or siloed delivery system, and we've not really had the need or requirement. In other countries where those standards are a lot stronger, a lot of them have shared records. So I think in France, they use a smart card-like device to keep track of records. So we've allowed this to continue, even though it may not be in the best interest of the whole system. Why? It's probably the best I can offer there. Relative to devices, personal activity, it's an area that I think has a lot of opportunity in health broadly and in an opportunity for open source. It's that platform thinking that allows a state agency like a Medicaid program to have an API structure that says, for all those people out there that want to deliver this information back, here's some ways to do it. And like I talked about, our push towards using commercial insurance payment methodologies and adopting Medicaid to that, I think we're going to need to, as state government, as a Medicaid, to adopt to what's emerging and say, we can take that information in. If it's working elsewhere, why should we say we need to change it or reinvent it? I think the interesting things come about because what do we do with regard to that data? How do we actually improve the program, or in our state, recognize where there's disparate needs so we can actually provide more support, more programs, dollars if it takes that, education if it takes that. So I think those will help us actually or inform our policy making over time. So.
John, question for you over here.
Thanks.
So I applaud your work on the transparency. 2 questions on this. Are the data sets available, or is it just through the interface? And then the second part is, from that transparency, what's happened? I'm really curious on that.
Certainly. 2 answers. Yes, you can go in and many of the data can be downloaded wherever we have it structured in that way. So you can go in and view it and sort it obviously within the app, but you can download it for your own use as well. Most of the work going on at the federal level as well is very similar to that. So what's happening with it? We think it started the conversation. We're providing data that starts to ask the question about why is the system like that? How does it relate to policy making? How does it relate to decision making? It's also, at a very practical level, taken a whole burden off of our staff who used to go and chase this data around when people asked, and we tell them it's available on the site, and we support them, and hey, click here or go through it this way as well. We think it's a start. We think it's an important start because often people are making policy decisions without good data. So that's the start of the conversation. We're working as well on how do we take some of the work that's going on in the private sector, or particularly in employer-sponsored insurance, to drive choices. Because in Medicaid, in some programs, but in general, the citizens do not have copays, so their out-of-pocket isn't related to in an employer program where if you make this choice over that choice. But we believe we can start to drive information to consumers to help them understand what choices they're making, and it may allow us to transform policy over time in that way. Thank you. Well, thank you very much for your time. It's been a real pleasure to be here with you.